Hello, and welcome to another episode of the Christian Reeve Podcast. Today's guest is an award-winning author, a consultant physician, and chair of infectious diseases all the way in Abu Dhabi. His name is Dr. Emmanuel Nsutebu. Welcome to the show. How are you doing?
Thank you. Thank you, Christian, and thank you for having me.
Oh, it's an absolute pleasure, sir. There's many different things we can talk about with you, but I think I'd like to always sort of just go right to the beginning and talk about how did you sort of get into your line of work, or what kind of drove, I suppose, your interest in sort of getting into your career?
So I'm originally from Cameroon in West Africa. I'm British now because I've been in the UK I was in the UK for a long time, and then I'm now based in Abu Dhabi.
Okay.
But
wow.
I'm an infection consultant, so I look after patients with suspected or confirmed infection, all types of infection. And infection is a very common problem in Africa, Cameroon, where I originally am from. So I developed an interest in infections when I was in Cameroon. And then also it's a specialty where people tend to get better when they're treated, especially when you make the right diagnosis. So it's quite rewarding seeing people treating them and then getting better. And then in the UK, when I was in the UK, I also decided to specialize in infections, also for the same reason. Very fascinating field. Everybody is different. People have different stories to tell you, and it's very rewarding.
Is there any particular memories of people that you've helped that sort of stick out in your mind when you look back over your career?
Oh, there's so many. Every person you encounter in hospital, every patient is special. And infectious diseases, we don't really have a protocol, so everybody comes with their story. And when we're taking a history, as we say, we start from scratch. It's like Dr. House, if you watch Dr. House, and we have to, like detectives, figure out what's going on. And so we always start with taking a full story, including all risks for infection, and includes pets, travel, hobbies, anything that you do. And often it's one clue in the patient's story that tells you what the infection is likely to be. So the most exciting bit of our job tends to be people who travel, who come back with infections, and we see all sorts. Sometimes things like maggots in different parts of the body, something called a bot fly or a tumbu fly, which with people sometimes that come with something looks like an abscess, but then when you look at it carefully, you realize it's actually a maggot under the skin, and we find exciting ways of getting it out. As well as that, to find people who because of travel also and exposure to different infections, will come back with all types of parasites. Parasites don't tend to need a visa to move between countries, so people may need visas, but the parasites don't. And even in the UK and in the Abu Dhabi where I'm working now, it's even more fascinating because the 80% of the population is from abroad, any part of the world. So there are a lot of people who also that we see on a daily basis with parasitic infections that we diagnose, worms in the intestines, in the liver, and other parts of the body.
In general, what are the kind of most common ways that people actually find themselves either coming into contact with these parasites and infections, or how is it transmitted? Like, does it come from, for example, animals? Is it a result of living conditions, or just particular climates and regions? Like, what are the most common causal factors?
It's a mixture, and it varies depending on the parasite, but most often it's food and water. That food and water that you eat, or meat that you eat. For example, tapeworm, get that from eating meat, beef or pork.
Damn.
And especially if it's from parts of the world where tapeworm is quite common, in Africa, Asia, South America. Sometimes it's contact with soil, because some parasites have a cycle where part of the parasite may be in sand or in soil, and if you're walking bare feet, it can get in through the skin and then
Oh my
go through your
God.
body and cause infection. And then mosquitoes and other insects also can transmit some. So yeah, all different routes, but most common it's in what we eat and what we drinking and water, or unfortunately when we're bitten by an insect or a tick or a mosquito.
Given that you're treating people from around the world, and obviously as a doctor you give them advice of things they should avoid, but are there instances where it's maybe not as possible for that person to avoid that, given where they're from, like what they're maybe, as you outlined, like if it's a problem with, say, the soil in that region, or the particular meat that they have access to, like how can a person avoid that exactly? Like what steps would they take?
So it's always important before traveling to seek help from a travel clinic, and lots of them in the UK, but most countries will have a travel clinic where you can go and seek advice, and you have experts, nurses, and doctors that can give you advice based on the risks of the country you're going to, and just taking sensible, simple measures like drinking factory bottled water, not drinking water that they sell in the street that is not factory bottled, eating food that is hot and just cooked rather than cold food. And if you're eating meat as well, especially if you're eating meat abroad, make sure it is cooked, not rare. And avoiding insect bites by covering up. It's not always easy. It's hot sometimes when you're in Africa, Asia. So wearing something hot, wearing jeans or long sleeves is not always very comfortable. But then also using insect repellents to help prevent bites from insects, sleeping under mosquito nets, for example, other measures that you can take. But we know it's not easy. These behaviors, often when you're on holiday, you may do that during the first few days, and then after that you relax, you're enjoying yourself, or you've had a couple of drinks. People then drop their guards and relax. And also, for example, there's a parasite called schistosomiasis, or bilharzia, which you get from water, some rivers and lakes. The parasite is in there from the snails. It gets into the water, and if you come in contact with water directly, then it directly gets in through your skin. You can imagine if you go to a lake like Lake Malawi, where schistosomiasis is quite common there. It's a very beautiful blue lake, and so I might have told a patient not to dip into Lake Malawi, but they go there and it's so blue and beautiful, and they just cannot resist the temptation, and they go in, especially when they see local people swimming in the lake, and that also affects the way people behave.
Well, I was going to ask about that actually. When it comes to, well, two things. One, consulting locals about how to overcome or avoid these parasites, and also, like as you sort of outlined there, like sometimes they're either not taking that advice, or I don't know, maybe they build up some sort of strength or resistance maybe to that. Like, are there any differences? Well, of course there are differences, but how do you consult and advise locals about how to avoid parasites and various other infections?
So for locals, it's a bit different. So if you take an example like malaria, which is a parasitic infection, mosquitoes transmitted, and when you're living in a local area, you do develop a bit of immunity,
okay,
which stops especially adults from developing severe malaria. And so people who are living locally, although you still recommend that they avoid bites, sleep under a mosquito net, they're not really at risk of having severe malaria as somebody who's visiting. So somebody like yourself or myself, because I've spent more than 6 months out of a malaria area, when I go back into malaria area, I'm just like any expat. If I go back to Africa, to Cameroon, because you lose that immunity within 6 months after around 6 months of leaving that area, you have to actually behave differently. And so we We remind people who are traveling that area to make sure that they maintain those measures throughout. And for the locals, what we'll focus on really is about reducing the risk of mosquito bites, and also making sure that they seek care early when they become ill, so that malaria can be investigated and treated. Obviously, when you're living in that area, you're always going to be bitten from time to time. You can't completely stop mosquito bites, but because of the semi-immunity locals have, the risk of severe illness is much less. But when you're living in an area where you do adjust, because if you're doing something on a daily basis, everybody else is doing it, it's very difficult for you to decide not to do it. So there's also the peer pressure and the way people do it here. And if you've done it for so many years and got away with it, you think I'm probably okay. It hasn't caught up with me for many years, and then unfortunately one day it happens. But most of those things are just simple things. I said it's about drinking factory bottled water. In locals, not everybody can drink factory bottled water,
right,
because it can be expensive. People may not have access to water, so boiling the water, filtering the water also helps. Eating fresh hot food also helps. It's a balance, doesn't it? Because we also have to live some sort of normal life. You can't be too careful, especially if you're living in that in that area. But just being sensible to reduce the risk. You can't reduce the risk to zero.
So you have 25 years of experience managing and treating infectious diseases, and as you mentioned, like parasites and stuff like that. What would you say have been your kind of biggest discoveries during that time, or maybe most surprising?
So surprising, I think it's really, with infectious diseases, it's just how uncertain we are, and every year we're faced with some form of a challenge. And the question really is not what is going to happen that is new, it is when it's going to happen. And so we've had COVID for the last 3 years. We've had monkeypox now as a global outbreak of monkeypox. And nearly every year there is an outbreak. People don't hear about it, but within infectious diseases, we're very alert and aware of outbreaks of new or strange infections happening throughout the world at every point in time. And we keep track of them because of the nature of our specialty, because someday one person may walk in from another continent, travel, and they have that rare illness with an outbreak happening in some other remote part of the world. So what has really changed now is with the pandemic, with COVID, and then the monkeypox, is the alertness about how easy it is for one infection from one area to move to another, and also the importance of the specialty. When I moved to Abu Dhabi, I was a single infectious disease physician in a big hospital, and trying to build a team and trying to raise awareness about how important it was for us to have a proper infectious disease department with a big team looking after infection. After COVID-19, we have grown. We now have a team of 5 physicians, 5 doctors, and working as a whole department, and they've seen the benefits. And I think most parts of the world, healthcare services and hospitals have now understood why infectious diseases as a specialty is important. They knew it was important, but I think they now understand why it's even more important, because of preparedness for emerging infections.
Well, what would you say are the biggest ways that those units or departments have changed as a result of things like COVID and such? Like, what has been learned in that short space, and what has been changed and adapted, other than obviously doubling staff and having more attention? And
it's more about planning and looking forward, and planning for what is resilience. What would happen if we have to have a surge in number of people developing a specific infection, but also being able to identify and control an infection really early, and having plans for how that were to happen. If that were to happen, how we would do that. So, for example, if we were to have 2 patients turn up in Abu Dhabi with Ebola, are we prepared to diagnose it quickly that having the laboratories, the doctors and nurses to suspect it, they send the samples, the laboratory to diagnose it, and then the team to look after these patients in such a way that we don't cause a spread of that infection in the hospital or within the community. So I think that has been the main thing, really preparedness and thinking ahead about what might be the next infection that will arrive, and then how would we respond in order to stop it spreading.
Thanks for sharing. You mentioned earlier about monkeypox, which I know very little about this. I've heard murmurings of it on the news, but since you are actually studying and have been for many years, and it's your kind of your field, what do you make? What can we learn? What do you understand about monkeypox? Like what can you tell us about that?
So monkeypox is a viral infection.
Okay.
It's really called monkeypox because it was first identified in a monkey, but the main animal that causes infection is not a monkey. It's a bit of an odd name because it was named because it was first discovered in Belgium in a monkey, but its main reservoir animal which it affects is not a monkey. It is an infection that is endemic, which I mean is that it's a regular infection in parts of West and Central Africa, and the reason why it become prominent now is just because it's left that part of the world and is now spreading in other parts of the world. But it's something that every year there will be hundreds and something thousands of patients diagnosed with monkeypox in West and Central Africa. The main animals that host this infection before it transfers to human beings is rodents, so rats and squirrels typically, and then with them getting infection and contact between them and humans, then it passes onto a human being and causes the infection. It behaves like chickenpox, so you have a rash which is like chickenpox, but it's different in that it affects the face and the arms and legs first, while chickenpox tends to affect your body and then moves to your arms and legs and face. And the rash is a bit different in terms of the way it looks compared to chickenpox, and it's also quite a painful rash, which the rash of chickenpox isn't, and then causes swollen glands with monkeypox. So there are some ways of a doctor or nurse differentiating a chickenpox rash from a monkeypox rash. And unfortunately, there isn't much treatment. It's not a very deadly virus. Approximately 1% of people who get the infection may pass away. And it mainly causes you to look ill because you've got a rash all over your body and your face, so you don't look very well, and you feel unwell, and you may get bacterial infections on top of the viral infections or other complications. But it's not a very deadly virus, and most people will recover, but it takes weeks to recover. It's not something that you recover quickly like chickenpox. Most people will take 3, 4, 5 weeks to recover. So they tend to be in hospital, especially when they're admitted for a long time before the rash may clear, and then they are no longer infectious, so we can let them get out of hospital. And there isn't any specific treatment. There are some different drugs that are experimental drugs, drugs that have been used for smallpox in the past, that are also now being used for monkeypox, because there are studies in animals that have shown that it may help. But now with the outbreak, the global outbreak, there's a lot of research being done. Like these things, whenever there is a global outbreak, that's when funding gets put into the service or the system to try and find a cure and to find a vaccine. So although it's a global outbreak, it's a bad thing. It may actually help find a better treatment and vaccines that may actually help prevent further outbreaks, just like it did with Ebola when it happened in West Africa many years ago.
Yeah, it's interesting how that happens, because I think COVID, for example, if nothing else, taught us that, you know, when it does get out of hand, there has to be a clear process in, you know, that we can kind of follow, that then can be replicated everywhere, kind of thing. Because we'd been warned by various physicians, and I think even Bill Gates said it many years ago, that something of this magnitude would probably occur one day, and we would be ill prepared for it. And lo and behold, we were. I mean, I do think that this particular virus is a little bit different to everything else, though, because as we were talking just then about, you know, how these infections come and go, and sometimes they exit the country, sometimes they stay contained. You know, I remember thinking about, in the 2000s, you had things like SARS, and I think swine flu, and mad cow's disease. I think there was. I remember seeing at least the British media was really making a big deal of it at the time. They were really just pumping, and maybe that's just media, I don't know, in general, trying to create fear and stuff. But at the same time, their coverage of it was very serious. And I remember being at school during the swine flu pandemic, and I remember being a little bit concerned about it. I was like, oh, well, this could potentially become really serious. And from what I understood at the time, it had been sort of contained, and they'd learned various things from it. But with this, I think, because that's how because we've seen that happen so many times, when COVID came along, I think most people kind of assumed the same thing would happen. Like, oh, well, that's just in some part of the world. That'll get dealt with. And then, yeah, suddenly now it's everyone's problem. But I don't know. At the same time, it's interesting, because I'm starting to really monitor people now. This sounds weird, but as far as like how people's behavior has changed. And for a long time, I mean, you still occasionally, where I am, I'm in Manchester in the UK, and I sometimes will see people still wearing masks and stuff like that. And, you know, great, you know, whatever works for you, like how you feel comfortable. And I was optimistic that maybe coming out of this, people's hygiene would get better. But it seems to me as though a lot of that's been forgotten. I mean, I won't go into details, but certain places you might go, and then you see people don't wash their hands, and you're like, how is this not possible? And then it just, I remember reading a medical study many years ago that, and I think this was like in the 1950s or something, in a particular hospital in the UK, they were trying to improve just general health, and they tested people washing their hands, and then they measured the death rate as a result of doing that. And I think deaths had kind of decreased by 80% as a result of doing that. I don't know how if that's a credited study or whatever, but I remember reading that and thinking it makes sense. And also, obviously, you go into any hospital, what's the first thing they ask you to do? Put away your phone, wash your hands straight away. You know, and that's always been that way. But yet we have this worldwide pandemic. People's attitudes and habits change for a while, but then they kind of start regressing and returning to normal. Why do you think that is? Do you think it's laziness? Do you think it's, I don't know, people just kind of thinking, oh, well, that doesn't matter anymore, now we're fine? Like, why do you think people don't take hygiene as it pertains to diseases as seriously as they should?
Really important question. I think it's complex. Human behavior is always very complex, isn't it? It's not, often people think it's knowledge, but it's rarely knowledge, really awareness. It's contributing to different things that contribute to people not doing the right thing. And you said it, even in hospital, where doctors and nurses know the importance of hand hygiene and using alcohol gel, you still find that it's not done as well. And we actually have programs in hospital to maintain hygiene. And if we don't do it well, you find that hygiene in hospital dips, and nurses or doctors may not use hand gels and may not clean their hands before. And you think they should know, shouldn't they? Of course they should. And that's because there's so many things that contribute to people's behavior. One, they may get comfortable and think it's no longer a problem because they're not seeing the patients they haven't seen a patient with infection. Similar to the public, you haven't seen somebody else with COVID recently, you think, oh, it's disappeared, so I don't need to do that anymore. Similar to the hospital, often it's because of pressure around you, and pressure because maybe other people are not doing it, so there's peer pressure. If the consultant, nurses, the seniors are not doing it, then the juniors say, oh, that's the way it's done here, I don't need to do it. The consultant is not doing it, so as a junior doctor, they don't do it. So the culture also which you contribute, and the same applies to the community. If your brother, sister, father, mother, family members are not doing it, you think, it's all right, that's the way it's done here. And then there's also all the different pressure. If you're really busy and you've got so many other priorities, then that no longer becomes a priority. If all you're doing is trying to finish the day or trying to survive, trying to finish your job and rushing around your job, then it doesn't become a priority to wash your hands anymore. It's all you want to do is do the next 10 things before you finish your shift, and then you drop that one. So these sort of environmental factors, as we call them, tend to also contribute. Hence why, to get people to do the right thing, you have to also make the environment conducive for them to be able to do it. If they're not being rushed, they have time to think, they have time to do things carefully, then they're more likely to do it. Making also the alcohol gels easily available, so you don't have to go and find it somewhere. Nearly every corner, every sink, every room, bedside is there, so you have no excuse not to use it because it's always there. And that also makes it much easier. So all these we have to sort of design the system to make it easy for people to do the right thing. And that's what we do in hospital. We consciously, as an infectious disease and infection control doctor, we're consciously looking at the whole hospital and stepping back and saying, how do we design this hospital to make it easy for people to do the right thing, including hand hygiene and other things to reduce the spread of infection. And I guess we need to do the same thing also in the community. At home and in the public places. How do we make it easier for people to do the right thing?
I think there needs to be more strictness, because as we were talking now, I'm just thinking of like different places and their attitudes towards these things. And in many cases, it's very lax. In a hospital, when I was growing up, I always remember, and maybe it was just because I was a kid, I don't know, but it always seemed really serious. Like I remember many doctors and nurses were always just almost demanding it, like, wash your hands, do this, wash your hands, do it now. And even to this day, there's a little bit of that. I mean, but it's not kind of like thrust upon you. And I think it should really. And one of the things you said there is that, you need to create an environment where it has everything readily available so that people can get access to that stuff that they need and do it. But even that sometimes doesn't seem to spur people on. Like, I'll give you an example. This is something that drives me and my housemate nuts. So we both go to the gym. Gym's 5 minutes from our house. It's great. But one thing that we don't like is the fact that it drives me crazy. So people don't clean like benches and weights and everything after they've finished using it. They just get on it and then leave. And sorry to be graphic, but sometimes they will leave like stains and sweat and everything there, which is disgusting anyway. But what baffles me is that, other than just a lack of respect and poor hygiene, like they don't think about like, well, other people have used this, and if I touch this, I am then getting those germs onto my hands. And then if I, don't think about it, wipe my face, whatever that's on my face, or I don't know, it's like that's how it starts. And it takes like a minute, 30 seconds. Like every time I'm at the gym, and again, I don't want to sound like, oh, aren't I so great? But like literally it takes 30 seconds and a minute. There's a station in the middle of the gym. You go there, you get your paper, you get the gel, you wipe it down, it's done. And there's a little station where you can wipe your own hands, and then that's it. And that takes a minute. That's it. But the point is, you have all that stuff available and people don't want to do it. So the only thing I can think is that they're just lazy. But then again, they're not told. That's the thing. Those things are available there, but there's no one saying, like no, like let's, for argument's sake, let's say there was someone just standing there going, "Wash your hands, clean it now." You do it because you don't want the big scary person to be angry with you. I don't know.
So they would do it when there's somebody around, and maybe if they're not looking, they may not do it. But what you're saying is, I think, is true, that some people do it naturally. Some people, it's sort of a habit, and that other people have to learn to do it. And in a gym situation, for example, if you're going to the gym, not everybody is told when they're being sort of induced to the gym that this is an expectation. That's something we do in hospital. For example, if we're getting new staff, we don't assume you're a nurse or a doctor, so you should know. You will be told, and also there is also what we say a no nonsense approach. So we expect that if you walk into a ward and you're seen not doing what you should be doing, the staff are expected to speak up and stop you. So we police each other, put it that way. Because team safety is better than individual safety. So you walk into an area, you're not using hand hygiene. We try and empower people to speak up and say, no, you stop. You've got to use it. And if you're not using it, you're not seeing this patient, or you're getting out of this ward. It doesn't always work, because sometimes people don't speak up. But we do our best to lead by example and empower people. And in the old days, we had what we consider the matrons, so old-style matrons of the wards, which is these days things have changed. But in the past, you will not, if you were to try and not do hand hygiene, or you will be walked out of the ward.
And that's how it should be. I agree with that. I think
they would not budge until they do it. Nowadays, it's a bit, people are still a bit lax, but we try and still encourage that all team members, if you see another member of staff doing the wrong thing, that you stop them, because it's a patient safety issue. It's a safety issue.
It's obviously not a very black and white issue, but it's interesting because, if you're in a hospital, most hospitals, you walk down those corridors or around their wards. I mean, how many different units of hand sanitizers will you see on those walls? They'll be everywhere, and there'll be signs and everything. But you need to be urged to do it. And you said before about the gym, or maybe someone's not being inducted to do that. And my first thought was, like, people shouldn't have to be told. They should know this from a young age. Like, for instance, I go to a bar with my friends. We go to the gentleman's restroom, and I see still, after a worldwide pandemic, still people not washing their hands, which is disgusting anyway. But given everything that's happened in the world in the last 2 years, that still baffles me.
Things have got better though.
They have. I mean,
it's got better, and we've seen with improvements in COVID. With the COVID pandemic, we've also seen reduction in infections that are transmitted the same way as COVID. So pneumonia caused by a bacteria called Streptococcus pneumococcal pneumonia. Numbers have gone down, and other respiratory tract infections, because of people wearing masks and hand hygiene. And so we've seen reductions in infections in most parts of the world because of that. So I agree, it's not where we want it to be, but COVID, I think, has helped people more conscious than they were 3 years ago.
You've worked quite extensively as a consultant physician, and one of the, let's say, clients of yours has been the NHS. I've worked in companies that have worked with the NHS before, and I mean, you read about how the NHS is managed and mismanaged in the media anyway, but it's very interesting when you get close to it where you're working, and then you really start to learn how things really are. I just wondered if you could share maybe your thoughts on how the NHS is currently being run, and in general, what do you think could improve, or how could it be approached in a way that might be sort of more effective for running the service?
So I've been out of the NHS now for 3 years. Based in Abu Dhabi, in United Arab Emirates. So I really don't have experience of the last 3 years of how things are going in the UK, other than what I see on the news and speaking to colleagues, because I'm not at the front line anymore. But when you are out of the UK, you do value the NHS.
Yeah.
The NHS has a lot of strength, especially when you're critically ill and need care, because the care is provided purely based on need, and it's really high level care. And I'm saying that because I can now compare with what I see in Abu Dhabi. And you can get access to care at no cost with the NHS, while it is really expensive in other parts of the world, getting the type of care you get in the NHS with experts. And that has made me value the NHS a lot, being here. And especially when you see the cost of healthcare here and the variability. You may go to a hospital and you get not very good care, you go to another one and you get really good care. In the NHS, there's more uniformity. Most hospitals will have good teams of nurses and doctors working together to deliver most of the services that are needed. So that has made me actually reflect and value the NHS. I think we'll come to the book and the story of sepsis. I hope but I also worked in the NHS as a clinical advisor for the National Health Service for sepsis. So as well as doing clinical work, looking after patients, I was also trying to improve services in the NHS.
Mm. Yeah, this is why I wanted
yeah.
to kind of ask you about it, because obviously being an advisor, a lot of what that role involves is kind of looking at what they're doing and then kind of advising them, well, this might be how I might approach it, or this based on my experience or what I know from abroad, or etc. Like this is, yeah. And it's interesting because the NHS is at this point in time predominantly still a public service, but certain parts of it are privatized, and increasingly more and more that's changing. And it's just a very confusing time, I think, just on all fronts.
Yeah. You really raise an important question about advising the NHS and how and the experience of working in the NHS and improving services. And I wonder whether, in order to answer that question fully, I should really talk about the story and how I ended up doing the sepsis improvement work with the NHS.
Please share it. Yeah, please do.
So the book which I've written, which is From Struggles to Success, how your struggles can make you better, stronger, and more successful.
Do you have a copy of the book to hand on you?
I have a copy of the book. Yeah.
Let's just share it in the thumbnail. Look at that. Can you see it?
Yeah, you can see it.
There we go. Struggles to Success. There you go.
Yeah.
Fantastic.
And how you? So this book I just published last month.
Oh, congratulations!
And thank you. And the book has a story within it, and then it uses a story to teach the skill of how to turn around a major challenge in life into a success. And the story in the book, which I won't tell in detail because you've got to get the book, but I'll give you a hint of what it's about. In 2003, in a hospital in the northwest of England, at that point I was a junior doctor, working as a senior house officer, as a junior doctor. And I arrived at the hospital, took my bleep, and I was on call, and just put the bleep on my belt, ready to start a ward round. And the bleep went off, and it was a crash call. So somebody who had a cardiac arrest in the maternity ward. So when you hear maternity ward crash call, you know it's a young person, because it's only be a young woman pregnant in the maternity ward. So I knew it was something. All crash calls are serious, but this is a young person that was arrested. And so I rushed to the crash, to the ward, went in, And to my shock, the person who had crashed was Delphine. And Delphine was a close friend of mine. And she had been in hospital, and I knew she was on that ward. She had been in hospital pregnant with a set of twins after IVF. And I'd seen her the night before I went home. Her partner was my very close friend, and we were neighbors. We lived 5 minutes away from each other. And so Delphine had arrested, and I went to resuscitate Delphine. And I initially resuscitated and started resuscitating. When the others came, I told them I knew Delphine and I couldn't continue when there were enough people, and I had to step out. And unfortunately, Delphine and the twins, she was pregnant with the twin boys, they didn't make it. They passed away. And Delphine had developed a condition called sepsis. And she had developed that in hospital. She had come to hospital because she was at risk of losing, having the babies early. And they had done something called a cervical string. They'd done a procedure to try and stop her from delivering the babies early. But because of that procedure, that had led to an infection in her womb. And unfortunately, she became unwell at night, and it wasn't recognized that she had this infection, and then went on to develop sepsis, where her organs failed as a result of it. And she deteriorated in hospital and got arrested in hospital. And it wasn't diagnosed early. And that is how we lost Delphine. Now you can imagine, as a junior doctor, going to resuscitate a friend who you'd seen the night before, who was in very good health. Delphine was 30 years old. She was a midwife. Everything was great in life. She had just bought a house, become pregnant through IVF, was getting ready to get married, become a midwife, bought a car, have a driving license. Everything was happening. Then she went into hospital, and then that was it. And as a junior doctor, you can imagine, I thought there's nothing I could do. How do you change a system? How do you stop this from happening from somebody else? And I just put my head down as a junior doctor, and we grieved, and then I had to finish my training. So I finished my training, and then I became a consultant in Liverpool. And one day I was in Liverpool as a consultant. It was a great job in the Royal Liverpool Hospital. And then one of my colleagues brought a complaint letter from a patient, and the complaint letter was in summary was saying, why was sepsis not recognized? Why did I come into your hospital with sepsis and it wasn't recognized? Why did all your doctors and nurses miss it? Why did I not get antibiotics within 1 hour? And this person is also a young gentleman who had developed sepsis from a throat infection and ended up in intensive care after many hours in hospital without the right treatment. And he written a complaint letter to the department saying, why did this happen? And so my colleague consultant brought it to me and saying, what do we do with this? And I read it and I said, it's pretty obvious. We apologize to the patient, and we've got to do something different. We can't have this anymore. And you see, I was then remembering what happened to Delphine, saying this is it happening again in Liverpool. It happened in another hospital, and now it's happening again. And so I decided to take that letter to the medical director of the hospital, and we had quite a good conversation about how we needed to do something completely different. And he agreed that we couldn't just educate people and tell them what to do. It was not just awareness, which is what you were talking about, but we had to completely redesign the hospital to make staff do the right thing. And so we developed systems, teams, working on changing the culture in the hospital, as well as education. And within a few years, we had completely changed sepsis recognition and management in the hospital. And we were saving lives in Liverpool. And we did similar thing in other hospitals in the northwest of England as a group. And that's when I was asked if I could help be a clinical advisor for NHS England. And that brings me to the answer to the question you are asking. And similarly, as a clinical advisor, what we're looking at is it's not an education and awareness issue. Nurses and doctors know, most of them know what to do in terms of recognizing and managing sepsis. The question is, how do we make it easy for them? And so how do we make the systems in the hospital easy for them to be able to do it? How do we build teams to support this happening? And simple things, for example, an example is screening for sepsis. So we introduced something called Sepsis Screening, and it became something that was part of hospitals were being measured on how good they were. And so anybody who comes to the hospital with an infection or they measure the blood pressure, pulse, and oxygen levels, and they're low. If the patient looks ill because of those measurements, then has the healthcare worker thought about sepsis, and they screen for sepsis. So they're thinking about sepsis for every sick patient or every patient with infection. And that's something that we also designed systems to make that happen within the NHS, and it's still happening now. But those are systems that is not just telling people what to do, but develop systems that make people do the right thing. And then building teams. So for example, in Liverpool, we had sepsis nurse team. So if you could come into hospital with sepsis, just like if you're coming with a heart attack, and they'll call the cardiac team, the heart attack team to come and see you straight away and make sure they do a certain number of things within the hour. With sepsis, also the team is called, and the team come and support the other members of staff, and they do what's necessary within an hour. So in Liverpool, within a few years, we then had, instead of having all these incidents and people who had suffered because of sepsis or unfortunately lost their lives, we're having people actually praising us because they've come to hospital and sepsis was recognized, and within 1 hour they were treated, and they got out of hospital very, very quickly with little complications. So it's really about, going back to the culture, teams, and systems. And to take this a bit further, I told you initially I was from Cameroon. And whilst working in the NHS and doing this improvement work in the NHS, it occurred to me that there's more sepsis in Africa than any part of the world where infection is so common. But the same improvement works that happen in the NHS and in England or in the US was not happening in Africa. So I tell the story in the book as well. So we decided to create the African Sepsis Alliance. And when we were creating it, it was, no, you can't do this. It's not going to work. You're in Liverpool, for God's sake. How are you going to create the African Sepsis Alliance based in Liverpool and make this work? People have tried. But we created the African Sepsis Alliance with people all around the world, with linked on computers. And we started a team of people all over the world working on the African Sepsis Alliance. And within a year of creating the African Sepsis Alliance, we had developed an organization as a charity. We had education events in Africa, conferences, teaching and training healthcare workers, nurses and doctors in Africa. We had meetings with the World Health Organization. We had campaigns online with something called the Kampala Resolution, advocating for improvement in Africa. And then with the Liverpool School of Tropical Medicine, my colleagues who were working there, we set up we applied for research funding. And we managed to get £2 million of research funding to do sepsis research in Africa, to answer some of the questions in Africa. And now we've got 10 countries in Africa working on the African research collaboration on sepsis, answering some crucial questions and producing really useful information now to help improve sepsis recognition and management in Africa, because sepsis in Africa is different from sepsis in the UK. Population is younger, the infections are different, so you can't just do the things we do in the NHS in Africa. You have to do it differently. So this research project is determining what we need to do in Africa and helping bring about the change. And And there's much more that's happening with the global sepsis lines that we work with. But the story, and coming back to it, is Delphine was from Cameroon. She was British, also based in the UK. She passed away in 2003 as a result of sepsis. And it was a tragedy. It should never have happened. And we could have after all the crying and that, left it as it is, and it will still happen to other people. But we decided to do something about it in the UK and started off in Liverpool and did the sepsis improvement work in Liverpool in the northwest of England, and then with the NHS, and then ended up creating the African Sepsis Alliance to save lives in a place or a part of the world where sepsis kills more people than in any other part of the world. And all this is back to Delphine's story. And it's about how you turn a struggle in life. And Delphine's passing away was the biggest struggle I've had in my career. You can imagine as a doctor what it feels like going to resuscitate a friend who passes away, who developed an infection in your hospital and doesn't survive, and the effect that it can have on you. But being able to take that and produce something really positive and turn around a struggle into something quite successful. And that's the basis of the book, Delphine's story. But then also the experience, life experience in Liverpool, in Abu Dhabi now, with COVID and other work that I've done in Abu Dhabi. Turning a struggle into success is actually a life skill. And then that's why I wrote the book, because I've actually realized this is something that everybody needs to learn. So whilst it's a story that starts with sepsis and then a full turn into something successful and how you turn around that, it can be applied to everything. We've all had problems with COVID. People have lost lives. People have become really ill. People have lost their livelihood, homes, jobs, incidents at work. Do you know anybody who hasn't had a major struggle in life? Everybody has. And people are still going through it with now. And everybody who has done something significant in their life, some people you consider successful, if you listen to your story, you'll find a major struggle. And Nelson Mandela going into prison and coming out to change South Africa and stop apartheid, Whitney Houston, Oprah Winfrey, Churchill, everybody. If you read their biography, you will see what I'm talking about. And struggles in life are gifts when you know how to use them. Because a problem or a major challenge is actually a gift. And in hospital, when there's an incident, yes, it should never happen. And with Delphine's story, I've obviously learned how to turn around incidents into something successful. But whenever there's an incident or a problem, what I do see is an opportunity to completely change the system and get it better. It's an improvement opportunity. And if we develop that skill in life, it's a life skill. If you develop that, you become a much better person. And so this book is about the skill. And in the book, I've also developed a 5-step model, which you can use. And I've used it often. And I've also seen people use it, and I've coached people use it. So it's a 5-step of how you change a major struggle into success, whatever it is. And the more you do it, the better you become. It's like going to the gym. The more weight you lift, you develop muscle. The more problems you solve and you turn around, well, you become better at it. And you become stronger and better as you do it. And the less you do it, the less successful and the less able you are to do this. So this book is about that. And it tells Delphine's story in a lot of detail. And then it goes through the different, the 5-step model, which I refer to as my 5-step model of changing a struggle into success. And also gives you really tips about how you go through those different steps. So yeah, that was a long answer, but I hope it covered what you were saying.
Perfect. Thank you so much for sharing. Really appreciate it. Well, given everything that you've told us, I mean, what did it mean to you to win the 2018 Global Sepsis Award?
So it's an honor, really an honor and a privilege to have won that, and it's also dedicated to Delphine, because all the work that I do with the teams and people. Otherwise, it's all back to Delphine, giving back to Delphine, make sure that they're making sure that Delphine's life was never lost in vain, and that something good comes out of it. And that's really what keeps driving the work that we do now. And the Global Sepsis Alliance Award actually came with some money, and that money is what we also use to run the African Sepsis Alliance. So it went back to the African Sepsis Alliance as funding to also help develop educational events for people in Africa on sepsis.
Fantastic. That's really good to hear. You know, that it's not just, which is great in of itself, but something that you can use to then help people even more. It's thank you so much for sharing. Fantastic stuff. A couple of final questions here for you, just general questions. What's the best advice you've ever received?
So the best advice I've ever received is from seniors and mentors and I actually put it in the book. So the 5-step model is, the first step is developing clarity when you've got a major problem, a major challenge. And the second one is developing commitment, and the commitment to change. And then the third step is developing a team or collaboration, a team to help you with the change. And the fourth step is developing a plan. And then the fifth step is implementing the plan and taking action. So there's a 5 step. And for me, and different people, when you learn this model and go to detail of it and you apply it to a problem, you find that you'll be different parts parts you're really good at, others that you're not good at, and that's why you develop the skill. You work on certain aspects. Some people are really good at understanding the problem, but then don't do anything about it. They don't have the commitment, or they don't. Some people are really good at building the teams, and they're very collaborative. They build a team, but they can't do it. They're not good at taking an action. And so we all have different strengths, and teams have different strengths. So for me, the most important thing that I've learned is not to solve a problem you don't understand. And so when faced with a problem, you cannot hit a target you can't see. And so, and as also with leadership, what I've developed and learned most important thing is to stop and think and reflect before you start trying to solve a problem, because you may find yourself solving the wrong problem. So when you're faced with a crisis and a problem, rather than rushing and trying to find a solution, stepping back a bit and trying to understand the problem before you go into it, and not rushing that aspect of starting to tell people, do this, do that, do that, do that. Actually, let's step back and try and understand the problem. And then also being able to, learning to develop commitment before you solve a problem. So we often get frustrated, and I could sense some of the frustration you were talking about. Other people in the gym not doing well either, and I do that very regularly, and we see that often people may know what to do, but they're not doing it. And so developing the commitment to do it is, and developing knowledge is not commitment. Knowledge is knowledge is not commitment. Knowledge is here. Commitment is the heart. And to get commitment, you have to get people emotionally involved.
Right.
And they have to feel their heart race and feel as if status quo is not right. They have to be able to want that change. But knowing it doesn't mean I want change. And learning that also has been really important for me, knowing how to create commitment. So when you walk into a team and say something bad has happened, they know if something bad happened, but they still haven't committed to change. So what you do is actually trying to get them to commit. And the most important thing I've learned is telling a story. Okay. Using stories. So as a doctor, you're taught a lot of how to use evidence and research, which is important, and I do still use it. But I also use stories to get commitment. So when I tell any of my colleagues Delphine's story about sepsis and her passing away, or another patient with sepsis, there is no argument about what they need to do once they hear Delphine's story. I can bring tons of research and I tell them this is the research as well, but what actually makes them change is their heart. And so building that commitment is important. And what I do also in the book is teach people how to build commitment and use my experience of how to build commitment. So I think for me, the most important things I've learned is clarity, getting to how to get to understand the problem before you solve it, building the commitment, and then also the teams. Getting how to build a team to solve the problem.
Thanks so much for sharing some really, really amazing advice there. This one's a little bit different, but kind of along the same lines. What's the biggest life lesson you've learned so far?
Biggest life lesson. That's a very profound question. For me, the biggest life lesson I've learned is, and that comes back to the importance of the team, is how important family is, family and friends. How important family and friends are. For me, that's the most important life lesson. And everything you do in life, whether it's at work or even at home, revolves around your family and friends. And so you need to have people around you to help you, support you in everything you do in life. And even at work, your work you're doing is supported by the people and your family and friends, and you're doing it for your family and friends. And so one of the things I've learned is never to minimize the role of family and friends, and to always prioritize family and friends. Again, going back to Delphine's story, the work we've done after Delphine passed away would not have been done if Delphine wasn't really a true friend. And I keep doing it because it's Delphine. And a lot of the things that I do, I also do it because of my wife and kids. Got 3 kids, 3 daughters. And this book that it took me 4 years to write this book. And the people who kept me going is my wife and kids, my daughters. And they're the people who kept on, and that's what about building a team. They're the people who kept on saying, Daddy, where are you with this book? When is it coming out? Why hasn't it come out? Well, it's been, you said 6 months ago, you said 1 year ago. And they're the people who kept me going. So for me, it's family and friends. I've also, as a doctor, I see people who unfortunately are may not be in a good state in their health and life. And whenever you see people who may be terminally ill, quite often the regret they have is not having spent enough time with family and friends. And so I also use the saying in the book that a wise man learns from their mistakes, but an even wiser man or woman learns from other people's mistakes. And what I observe when I'm looking at the people who are terminally ill is they're often regretting not spending enough time with family and friends. And so I've certainly learned that now is I try whenever I can. I work hard, and there's a lot I do, as I said, in my spare time, charitable work, but I also find time to spend time with my wife and kids and my father and mother and other siblings, because it's so important. Those are the people who really also remember you when you leave work, when you stop doing what you do at work. They're the people who really remember you. They will remember you at work, but your family and friends are the real people who are going to remember you. So I've learned that, and that's the most important thing I've learned, the importance of family and friends.
Amazing. Thank you so much for sharing. As we draw things to a close, do you have any upcoming projects or some final thoughts that you'd like to share with our listeners?
Well, it's after the launch of the book, it's now available on Amazon and other outlets, regular outlets for book sales. It's really just promoting the book, and trying to get to as many, because I see this as a life skill. I also see this as a purpose, my purpose in life. Yes, so sepsis and Delphin's story and Sepsis Alliance, African Sepsis Alliance, but it's actually about teaching this life skill to children, others who can benefit for it, because it can change people's life. The life skill of changing a challenge, a major struggle or a challenge into success and coming back, and how you can do that very effectively and efficiently. So what I'm doing now is really promoting the book, trying to get as many people to know about it as possible. People share it, learn, and it's learning the skill of turning a struggle into success. And I want to do that more also in schools, because I can see that children will benefit really from it if they learn it really early. People learn it really late. Some people learn it when they're working or university, or even leave university and still don't learn it. And then they get a challenge in life at work and it completely breaks down. When if they've learned that skill early, it makes such a difference. So but the project now is getting people to learn this skill of changing a struggle into success through the book. And I said the book is available on Amazon.com. You either search for my name, Nsutebu, or Struggles to Success, and it's available there on ebook and also paper.
Excellent. Once again, a massive thank you for sharing your story here and for coming on the show. It's been an absolute pleasure. Thank you so much for your time.
Thank you for having me on the show. It's been a complete pleasure. I really enjoyed it, and thank you. Thank you again.
Thank you, sir. And to all the listeners of the Christian Reeve Podcast, as always, I hope you enjoyed the episode. Be safe, be well, and I'll see you in the next one.